Everyone. Uh, Welcome you all. It's my honor and privilege to officially welcome all of you to our first National Plural MDT. This is truly a landmark occasion, bringing together leading experts from across the country to discuss difficult cases, challenging cases of pleural diseases. This platform has been created to discuss, learn, share, and collaborate with each other uh, to improve the way we manage patients with pleural diseases. And we want to improve the standard of care for patients with pleural diseases. And this is the platform we have created so that we can do the same. Uh, Before we start, let me introduce our panelists. We have four esteemed panelists with us. Dr. Arvind Kumar sir, from Medanta Hospital, Delhi. He is the chair of the Institute of Thoracic Surgery and Lung Transplant. Then we have Dr. Aparna Erodi. She is the professor of radiology at CMC Vellore. Dr. Nagarjun Matru, he is a senior pulmonologist at Yashoda Hospital, Hyderabad. Then we have Dr. Radhika Banka. She is a senior pulmonologist at Hinduja Hospital, Mumbai. We also have three esteemed faculties who will be presenting their cases today. To start with, first is Dr. Mohan, who is a thoracic and lung transplant surgeon at Medanta Hospital, Delhi. Then we have Dr. Avinash Nair. He is at CSI Kalyani Hospital at Chennai. Then we have Dr. Manas Menga, again a senior pulmonologist at Fortis Hospital, Mumbai. Now we'll start the cases from here. I invite Dr. Mohan to present the first case.
Thank you, sir.
Dr. Mohan, please.
Yes, sir. Thank you. So can you see the screen?
Yeah.
Yes. Good evening, one and all, and welcome to the first MDT. First of all, I would like to congratulate Dr. Sushil Jain and Dr. Richa Gupta for starting this wonderful venture where pleural diseases can be discussed as a subspecialty. The challenging cases can be shared with everyone. So the first case, the case that I'm going to present is a very challenging case where we're not able to differentiate preoperatively, is it a pneumothorax or it a bulla. So this patient is a 55-year-old male, a smoker, had history of multiple times pneumothorax. He had it twice before coming to us, once in 2012 and in 2018. In both the situations, he was managed with intercostal drain only. And then third episode, he had similar kind of episodes about this. Actually, this case was about 2 years back. So 2 years back, he had this, the present episode, I would say. And this is the chest X-ray he presented with. Which is showing a large right-sided pneumothorax. It's not complete pneumothorax. The upper lobe was probably it was stuck, and the pneumothorax component was the loculated kind of thing. It is in the right mid and the lower zone, and the underlying collapse we can see here. So ICD was put in this case. However, the lung did not completely expanded. So they waited for a few days. They put some negative suction and all that, but the lung could not expand completely. So at this stage, the physician thought, I don't know what is his thought, but he put 4 grams of talc through the ICD into the chest cavity. And
Mohan, can I disturb you? Sorry.
yeah,
We
yes.
got a message from the attendee that they are not able to see any slides. Vinod, can you please help us on that?
Ma'am, we are able to see the slides. It's visible to us.
The attendee has put up the message.
Okay,
We can't see
let me
any.
check.
Yeah, please. Okay, the other one we have got the slides are visible. Sorry, Mohan, please continue.
Yeah, sure, ma'am. Thank you. So after the third ICD was inserted for the third episode, the lung did not expand completely, and talc was put, 4-gram talc through the tube, and ICD was removed. So the patient continued to have symptoms, and he underwent a CT scan at this stage, which showed this picture, and he was referred to as a case of a large bulla, which requires a Watt's bullectomy, and then at this stage they came to us. So this is the preoperative CT scan. So shall we have the radiology discussion at this stage, or
Yeah.
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 so
Dr. Aparna?
Yeah. Good evening. Yeah, can you hear me?
Yes.
Yeah.
Yes, Dr.
yes,
Aparna.
we can hear you.
Yeah, so I think it's sometimes quite difficult to differentiate whether it is a giant bulla or a very loculated pneumothorax. We do see some septations within it, and it has like a convex margin medially. So I mean that is one of the signs people say where you can have like a concave margin in the medial aspect towards the chest wall in a loculated pneumothorax, but if it is under tension, I guess even pneumothorax can have that convex margin. But especially if you see that in the upper and mid portions, but when you come more inferiorly, it's kind of wrapping around the diaphragm, and it would be nice if we could actually scroll the images and see the coronal and sagittal also to get a better picture. But yeah, I would like to say that it's quite difficult, but maybe it's more like a loculated pneumo than a bulla. Maybe there are some bullae underlying it. There's some one thick walled like a cavity in the lower zone in the uh, last in the third last row in the second and third image. There is something that looks a little thick walled. Maybe that could be a bulla.
Yeah, and in the opposite lung, there are some cystic or bullous lesions also present in this scan. I'm sorry about the CT scan. We don't have
Yeah.
any video of that because it was a
Oh.
2-year-old before CT and the case.
Oh.
So with this, so we also had the same opinion that it could be possibly a loculated pneumothorax more than a bulla. That was also our opinion before proceeding for the surgery. Since there is no complete lung expansion, so we decided to go ahead with the diagnostic VATs and then proceed according to the findings that we find during the surgery. So we did, first of all, diagnostic laparoscopy. So as soon as we entered the chest cavity, it is not a bulla actually. It is the loculated pneumothorax. You can see the underlying lung was collapsed in the right middle and lower zone, and we can see the irregular lung adhesions to the chest wall, mainly in the posterior part. You can see we are trying to mobilize the lung from the posterior chest wall. So what the actually happened here is, in cases where the underlying lung is not completely expanded and talc was put, you can see the white sheet of talc where the lung was actually densely stuck there. And you can see with how much great difficulty we were able to, we are mobilizing the lung here. And during this process itself, we can create some kind of abrasions over the lung and can be a source of post-operative prolonged air leaks. So with great difficulty, it took us about 1.5 to 2 hours to just mobilize this densely stuck lung that was plastered to the chest wall, where all the talc that was put into the chest actually got accumulated because it was put from a chest tube, that most dependent position, all the lung went there and just it stuck there. And because of probably the previous two ICDs also, the lung was densely adherent in the apex region also. You can see the sheet of talc, which caused the accumulation along the posterior chest wall here. So in this surgery, and this is a few bit of a surgery that we did, we completely mobilized the lung, with which the lung actually completely expanded in the post-operative period. So this is our post-op one picture where you can see the both ICDs, one at the base, one at the apex, and the right lung is now completely expanded. And this is the 3 months post, the patient came after 3 months for the follow-up, and the lung is completely expanded and the patient is absolutely doing well.
Yeah.
So this is the brief about my case.
Thank you, Dr. Mohan. Very nice case. Can you just go back to the previous slides? Oh, okay. Can you share the slide again? To the CT scan.
Yeah, exactly.
This question is for Dr. Aparna. For the sake of the students, PG students, and the youngsters who are there with us, can you help us to, can you tell us how one can differentiate bullae from a pneumothorax in a CT scan as well as in an X-ray? Is there are distinct things which you have to look for before we say that this is a possible pneumothorax or a bullae? Can you please elaborate on that?
Yes, sir. Sometimes it will be difficult because I mean, if it's not a loculated pneumothorax, it's easy. When the pneumothorax gets loculated, then it can mimic a bulla. So that is the issue. So if we have like coronal, sagittal, and all the other planes, the bulla would tend to be little more rounded than the pneumothorax, which will be elongated in the craniocaudal direction. That is one thing that we can look for. The other things would be like they say that if it is a pneumothorax, the medial margin will be concave towards the chest wall as compared to bulla, where the medial margin will be convex. So here, if we see the upper cuts, it is kind of convex, but when you see somewhere lower down, it does have a little bit of concavity. And in this case, what I thought pointed more towards the pneumothorax was if we go to the lowermost last 3 rows, we can see that it's kind of wrapping itself around all the structures, including the diaphragm and all that. So that would not probably be there in a bulla is what I thought. So it is partly loculated and partly free kind of pneumothorax, I guess. That is why it would look like that.
Okay. And is there any way we can differentiate them on an X-ray? Can we go back to the X-ray?
One more point would be, sir, if we had multiple serial X-rays, then we will know like this bulla has been there for years together. Many times these bullae will be there for so many X-rays, we would be seeing them. Whereas pneumo would have come new.
Go back to the previous X-ray. So is there any way to differentiate on this or no, we can, it's difficult?
Yeah, I mean, it's difficult, but here we can kind of see that there is almost like one level and again, it's more lower. And the way that craniocaudally it is elongated, that is one thing that may help. And the upper edge is having that concavity, that will also a little bit help. But yeah, I think it's difficult to say for sure. But if we had a previous X-ray and this has newly come, that will definitely help us.
Yeah. Thank you.
Sir, Sushil sir, I think we'll just add up one more question to Dr. Aparna, what the people are asking again and again. How can we, is it possible to differentiate pneumothorax and bulla based on chest ultrasound?
I don't think so because that if it is a huge bulla, maybe it may not move, but maybe we may be able to see the sliding sign, I guess, if it is a smaller bulla. But if it is a kind of under tension, I'm not sure. Maybe you are better suited to answer that, Dr. Richa.
I think because once the air comes in, no, it is a bad conductor of ultrasonic waves, so it becomes almost difficult to differentiate. And ultrasound is when we talk about pleural diseases, we say that ultrasound is the best modality, but this is the place where it fails, is what I would say. Over to you, sir.
I think we move on to the next question. Thank you, Dr. Parna. The next question is for Dr. Arvind Kumar, sir. Sir, this is what I'm talking about is a relatively common situation which we all see, that if an ICD is inadvertently placed in a bulle because of lack of judgment or by mistake, what would be the consequences and what should be the next step in managing such patients? If someone has placed an ICD into a bulle, considering it as a pneumothorax, and then he is in trouble, so what should he do next, and how we manage such cases? Because this is a relatively common situation, sir.
Thank you, Dr. Sushil. And first and foremost, heartiest congratulations to you and to Professor Richa Gupta for this idea of a national pleural MDT. I think it's a wonderful idea. And the way you have set it up, it's a good clinical thing that one clinician presents a case and you have a radiology clinicians, different. So it's like a multidisciplinary. So you are discussing X-ray, CT scan, then you are discussing the medical aspect, the surgical aspect. So wonderful. I think it's a first initiative of its kind, at least that I'm aware of. Maybe at individual institutions level, it might be happening, but not at a national level. So kudos to you. Congratulations to both of you for coming up with this idea and executing it so nicely. Thank you. Now coming to the question, what was the question? I forgot.
ICD in a bulle. If someone has placed an ICD in a
So
bulle,
if somebody
as a pneumothorax.
accidentally, so if you accidentally put an ICD into a bulla, see, immediately there will be air leak. So one would think that, okay, there was pneumothorax, you put tube and air is coming out. The difference will be if it's a pneumothorax, air will come out for a while and lung will expand thereafter and things will settle unless there is a continuing air leak. However, if you put an ICD into a bulla, there is going to be a significant air leak, and there may also sometimes be bleeding, and later on you might find an air fluid level actually coming up inside that bulla. How much of air leak happens will depend on the connections that the bulla has with the lung. If it's a peripheral bulla which did not have air under pressure, you may have a little bit of air and it actually might even collapse the bulla in few cases. However, if it's a big bulla which had a lot of air under pressure and has a major communication with the airway, you are in for a major bronchopleural fistula. What we call typical bronchopleural fistula, BPF, means BPF. One of the bronchus will be communicating, and every time the patient breathes, every time the patient coughs, there will be air coming out. This might even interfere with your ventilation, especially if it's an elderly person with a compromised kind of lung, then you might even have difficulty. So we would, in such cases, watch very carefully. And if you strongly suspect that you put bulla and in a chest tube in a bulla and you have difficulty in maintaining saturation, it might even be a case for urgent intervention. So please be careful. And I must warn here that couple of people I have met, they harbor this notion that putting tube into bulla is one of the treatments of a bulla. So you were asking about accidentally putting it, I mean, the tube going into the bulla. I'm saying that I'm aware of people, I can't name them, who have told me that one of the treatments for bulla is to put a tube, all the air will get drained and then the bulla will collapse. And I asked them if there is a major fistula. They said, no, as the bulla collapses, the fistula will close. So please be clear, all students, putting a tube into a bulla electively by choice is not an answer, it's criminal. And if you accidentally put it thinking that it's a pneumothorax and it happens to be bulla, then please watch out for the amount of air leak and whether the patient is able to maintain the ventilation or not, and then proceed accordingly. Dr. Sushil.
Thank you. And so the next step after will be surgery. So all these patients will finally require surgery. Because if you have put inadvertently put a chest tube and you have a major BP, these patients will all require surgery. So there's no
So-
other treatment for these cases. That's what
So,
we
Dr. Sushil, when it comes to treatment for the bully, we divide them into two groups. One is a bulla, which is asymptomatic, and the other is which is symptomatic. Now, what could be the symptoms? So the one of the major symptoms oftentimes is a persistent cough. Because of the presence of bulla, they have a persistent cough. Sometimes it gets infected, so you may have fever and coming up, bringing out yellowish sputum, and there may be an air fluid level appearing. Third is it might have bleeding inside sometimes, so patient may present with hemoptysis. Fourth is it may rupture and cause pneumothorax, and then the patient presents acutely with pneumothorax. So cough, fever, hemoptysis, fever with purulent sputum, hemoptysis, and presenting with sudden chest pain and dyspnea. These are all symptomatic types of bully. And the other is asymptomatic, where patient doesn't have any symptom, but you do a chest X-ray and you find that there is a bulla. Now, the indication for surgery in this situation is if it's a giant bulla, which by definition is a bulla occupying more than 1/3 of the volume of the ipsilateral hemithorax. So if it's occupying more than 1/3, it would be a case for surgery, because left untreated, these tend to have high incidence of rupture, pneumothorax, and serious problem, especially if it's a peripherally situated. The other is in case you have serial X-rays available and you can show a continuous increase in the size of the bulla, and it's a young patient, and if you project over the next 5-10 years, it's going to go into the complications. So that case also, in an elective manner, you would opt for surgery. So Dr. Sushil, these are the various indications for surgery in bulla.
Thank you, sir. Thank you.
I would request all the expert panelists if they can just see the question answers also, and if they can at the same time, if they can type the answer as well, because it looks like people are interested and we may not be able to complete our session. So Mohan and Arvind sir, there is some question
Sure,
in the question
sure.
answer. So sir, if we can answer that, and we all will. So I just want.
Mohan will answer. He's good in typing. I may take long time.
Sure, sir. I would like to ask Nagarjuna. So, as a physician, when do you would like to do a pleurodesis in a patient with pneumothorax, and what is your choice of agent?
Madam, I was actually about to volunteer myself if nobody would have asked that question.
Yeah.
So in this case, when I was listening to the history, so there were two second episode of pneumothorax. Actually, presuming it's a spontaneous pneumothorax, and second thing, presuming that it's a primary spontaneous pneumothorax, at least grossly on the CT, I cannot appreciate small cysts, but Dr. Mohan has told me there are small cysts otherwise also. So if it's a case of a primary spontaneous pneumothorax, then if it's a second episode, then definitely we have to do a pleurodesis at the second instance, whichever means, but a pleurodesis has to be done. So in this case, at the second instance itself, when a tube was placed, a symptomatic secondary spontaneous symptomatic second episode of primary spontaneous pneumothorax, so if a tube was placed, a pleurodesis should have been done in the second instance. That is the first thing. So if you don't do the second instance, it is almost inevitable that you would get a third episode. And that is what exactly has happened. And in the history, I was not sure whether these first two instances were on the same side or not. I'm presuming that it's on the same
Yeah,
side.
they are on the same side. They are on the
The
same.
same side. So obviously, if there are two episodes of PSP on the one side, then you are just waiting for the third episode to happen, and that is what has happened. Second thing is, if it's a secondary spontaneous pneumothorax, then even in the first instance, you would want to do a pleurodesis. There are two reasons for it. One, the ability of the lung to tolerate pneumothorax is lesser in secondary spontaneous pneumothorax. And second, there is a much higher chance of recurrence with secondary spontaneous pneumothorax. So that is the two indications broadly when we consider pneumothorax, pleurodesis in cases of a spontaneous pneumothorax. Now, coming back to this particular case, if there were bullae or cysts identified in the first instance itself on a CT, because we don't have the CT, which was then at the first pneumothorax. then that itself would make it a secondary spontaneous pneumothorax, in which case you would have done pleurodesis in the first instance itself. So that CT we do not have. Then the last thing which I wanted to say was attempting pleurodesis when a majority of the lung was unexpanded. So in the X-ray which was shown by Dr. Mohan, when the chest tube was placed, only a small part of the lung expanded and the bulk of it was actually still unexpanded. So in such a circumstance, we would not proceed with pleurodesis. Probably that was the time we should have referred to a surgeon for intervention.
Yeah.
Had the patient been there, you wouldn't attempt the pleurodesis with a grossly unexpanded lung. The choice of agent at our center, we use talc, medical sterile graded talc for most of our procedures. So if the lung is expanded, there is no air leak, tube is in situ, we would just stick with talc slurry. But if you happen to do a thoracoscopy for whatever reason, we might do a talc powderage also. But now with the evidence that slurry is as good as powderage, if it's a tube in situ, lung is expanded, no air leak, then we would just do a talc slurry pleurodesis.
Yeah, exactly. I mean, something which everybody should know. Nagarjuna has put up really very, very valid points. And I also was wondering why they did a pleurodesis in that patient and then they removed the tube as well. So certainly it makes the job difficult for the surgeons, and we have seen in the video. Radhika, I wanted to know, is there,
Dr. Richa, can I just add a line to that?
please, sir, please,
Yeah.
please.
So I'm 100% in agreement with what Dr. Nagarjuna said. And I just want to reiterate this point because this is an error, Dr. Richa and Dr. Sushil, we see day in and day out. How does a pleurodesis with talc work? Talc is an irritant. Talc is not a glue. Talc is an irritant. So it causes inflammation on the surfaces. And when two inflamed surfaces are opposed to each other, they get adherent to each other. So the basic requirement for talc pleurodesis to be successful is for the visceral and the parietal pleura to be in opposition to each other. When you have a situation of a collapsed lung, where the visceral pleura is far miles away from the parietal pleura, you put talc, you are only inviting empyema, and a thick layer, you are converting it into a trapped lung. Unfortunately, it's a situation we find to be done very frequently. So a clear message that if the lung is not fully expanded, it's not a case for pleurodesis by any agent, talc or any other agent. Lung must be fully expanded, then only it will work. Thank you, Dr. Richa.
Thank you, sir. Radhika, I wanted to know from you, is there any role of negative suction in patients where we have put a chest drain for pneumothorax and the lung is not seen expanded? Or if yes, then what are the conditions? That is one thing. And if yes, is there any conditions or contraindication when we should not when we should not do suction?
So, firstly, if your lung has not expanded, then negative suction is definitely has a role to play. Uh, your and there are different devices that are available. So, one of the things that the surgeons commonly use is something known as a topaz, which is an inbuilt suction device, or the more traditional way is, having a chest tube and then connecting it to wall suction. So definitely there's a role, but again, it also depends in terms of how what the indication is. So if you've got a lung which is not expanding, you also need to be careful in terms of how much negative suction you're giving, because if there's a small BPF, excessive lung suction can also increase the BPF. So you need to be careful with the amount of suction that you are using. The other thing is negative suction can cause hypotension. So if your patient is already hypotensive on the ventilator, uh, already on inotropes, then negative suction can be a bit tricky. So then you need to use it with a bit of caution.
If there is a presence of any leak, can we still consider giving suction? I think surgeons won't agree with this.
Should I go for that?
Yes, sir. Please.
So, Dr. Richa, we use suction day in and day out. We have about 30 of these medulla and other digital suction machines in our ward. 95% of our post-op patients and other patients also are on suction. See, let me explain the reason. So many times when the lungs are collapsed for quite some time, and by some means you get an expansion, the lung does not expand fully. Or if there is a lot of air leak, you put a chest tube, the air is getting drained, but the air coming out of the lung is more than what is easily getting drained through the chest tube. So there is always some air which retains in the chest cavity, which leads to a persistence of some amount of lung collapse. And if you put suction on this, it helps in complete expansion of the lung. And we do it every day when we operate on empyemas where lungs have been collapsed for quite some time. They've been trapped lung. When we untrap them by doing a complete visceral pleurectomy, on table when the anesthetist backs very hard, the lung expands. But when you leave them on normal ventilation or a spontaneous breathing, it tends to have a partial collapse. So we put 2 chest tubes, put very high suction, 30, 40, 50, 60, sometimes even that, and get these lungs to expand, because these are very fibrous lungs where you need a lot of suction to help them expand. The problem is if there is a fistula, sometimes putting suction can increase the amount of air leak. So what we do is we have 2 things to watch. One is the lung expansion and other is an increase in the air leak. So we kind of titrate when your lung expands, that's one of the ways to actually close the air leak. Air leak happens from a collapsed lung. But when it's an expanded lung, the lung goes and sticks to the chest wall, and that surface air leaks tend to stop. So we watch them. If increasing the suction increases air leak excessively, does not cause much lung expansion, then we come down on the suction. But if increasing the suction helps in lung expansion, doesn't increase the air leak that much, then we go on increasing the suction. So there is no one size fit all for all patients. It's a hit and try. But suction definitely has a role, and all our thoracoscopic pleurodesis patients remain on suction for about 72 hours, which helps in the pleural and visceral surfaces being opposed to each other, giving us wonderful symphysis.
Sir,
Thank you.
one thing I want to add here, for surgical cases, yes, suction has been shown to have a role. But as far as if you go by our guidelines, they said that negative suction has not shown to be having a statistically significant benefit in non-surgical patients I'm talking about. I'm not talking about surgical cases. The current BTS guideline doesn't favor a negative suction. They say that it doesn't show much of help. The previous guideline used to say that you go for high volume and low pressure suction between -10 to -20, but then the current guidelines doesn't favor it. So, Dr. Richa, any take on that?
No, I agree, because at our place also, sir, of course, not defying what you are saying, you have a vast experience, but based on the guidelines as a physician, and we don't have those digital devices as well. It's a wall suction, which most of the time we have, or the Sinapi drain, which gives you some up to -30. So we prefer not to use, maybe it is because of the fear, I would fear, not to use the suction when there is a large leak.
Hardly.
If the leak is a small, then we are confident to connect the suction.
Dr. Sushil, regarding suction, having used it for almost 30 years now, and having used all types of suctions, those 3 bottles connected to wall suction, then regular suction machine used by some concoction, then we had some Chandni Chowk bought machines which we used, and finally we have now zeroed in on the medulla digital suction device. What is most important is for suction to be available continuously. When you use wall suction and connect it to bottle, patient goes to toilet, patient goes here and there. For that period, the suction gets disconnected and the lung goes down. We face this problem when we use Pleurivac, which is connected to wall suction. When the patient is moving, the lung goes down. You connect, it comes up. When we have digital suction, which gives you portable 24/7 suction, then the results are much, much better.
Thank you, sir. Thanks to you for the input.
And I would, extend an offer to any one of the participants if they ever happen to visit Delhi. I would earnestly request them to spare a day and come over to our ward and see about 30 people, 30 patients carrying that digital suction machine at various levels. They'll get convinced about the role of suction.
Thank you, sir. I think if we move on to the next case, now I invite Dr. Avinash Nair to please present the next case.
Yes, sir.
Avinash, please.
Is my slide visible, sir?
Yes.
Yes.
Yeah. Good evening, everyone. At the outset, I would like to thank Richa Madam and Sushil sir for this wonderful opportunity and for being part of this great Indian Pleural Network and the first Pleural MDT, along with all the august and esteemed panelists. Over to our case. We have Mr. X, who's a 60-year-old medical professional who presented with complaints of right-sided chest pain, which was short and stabbing in nature, which later changed to dull for the past 2 weeks. The pain was more on the lateral decubitus position on the right side and associated with dry cough. He had no other constitutional symptoms or sinister symptoms. Personally, he had no addictions. As part of his work, he works in rural part of Orissa and he travels a lot for his work. His general examination was unremarkable, except for the respiratory examination, which corresponded to a moderate pleural effusion, which had findings in the right infrascapular infraaxillary region, and the occasional crackles corresponding to the right axillary region. The other system examination was unremarkable. So with that, we did basic investigations. The chest X-ray confirmed our examination findings, and the blood picture showed us that the patient had a peripheral eosinophilia, and his routine blood investigations of liver renal function were normal, and the serology was negative. So he underwent a ultrasound screening, which showed a pleural collection, which is a hypoechoic collection. And under guidance, he was a diagnostic pleural tap was done, which showed a straw-colored effusion. The analysis showed that it was an exudative with eosinophil predominant. 87% of the total count was eosinophils. The cytology was negative. The routine culture, gene expert, and AFB spears were negative. His ADA was low, around 70. The microfibrillary, because of the eosinophilia, the other workup sent was microfibrillary parasite, stool parasite, which were negative. And he did not have any history of any trauma, any native medicine use, or any other medications. So we move on to the imaging. A PET CT was done as part of the evaluation. The CT part of the PET CT, I'd like to project now.
And we can ask Dr. Aparna to have her expert comment on the CT as well as the PET CT.
Okay, ma'am.
Yeah, sure. So we are seeing the brain now, which looks pretty normal. And because it's a whole body PET, so neck also looks normal. So we are starting to see the pleural effusion on the right side. It's like a mild to moderate effusion. I'm just trying to look for any pleural thickening or enhancement or nodules. I'm not really able to see any definite. Maybe in the lowermost sections, there's minimal thickening of the pleura, very minimal, but no real nodules or masses. The underlying lung looked collapsed only. I did not see any gross lesions in the lungs, but we can look at it once again. And a few nodes I saw, right hilar and paratracheal, very borderline nodes. Abdomen also grossly looks normal. No significant abdominal nodes. No ascites. Heart size was looking normal. Maybe the prostate is mildly enlarged. That's the only other finding that I can see. And obviously we'll look at the lung window also. And the
ma'am.
PET, we'll see if there's any uptake in the pleura or anything else. Yeah.
Sure, ma'am. I'll go to the PET, ma'am.
Yeah, sure. So brain usually shows lot of uptake, so that is normal. All the redness in the brain is a normal finding. So neck, we can look for any nodes. Salivary glands also can show normal uptake, so they are showing some mild uptake. No significant cervical nodes. So again, we're starting to see the pleural effusion, and there's no real uptake, no FDG avidity in the pleura. The nodes, the right hilar node shows some uptake. One subcarinal node we just saw, which showed a little bit of uptake. Since we saw some minimal enhancement of the pleura, so in the chest, I guess there was a chest tube site which had shown some little uptake. But rest of the pleura, maybe in that posterior costophrenic recess, whether there's some minimal uptake. But again, we're not really seeing any lesions or anything in the lungs. No nodules or thickening in the or masses in the pleura, no lesions or no uptake in the lungs also. There was one subcarinal node which was showing uptake, and there was some uptake along the site of the previous ICD. So very non-specific on imaging. I don't think we can really say anything definite based on the CT alone.
Yes. Yes. Thank you, ma'am. So with that, the patient underwent a medical thoracoscopy, and as you can see, there were two apart from a regular pleura. Otherwise, there were two linear irregular raised lesions in the intercostal spaces, as we can see in the picture, which were biopsied. And this is the biopsy slide which has been projected. You can see that there are definitely a lot of plasma cells. So it's a plasma cell rich, moderate to dense pleuritis with areas of eosinophilia. There were no definite granuloma or features of malignancy. The gene expert of the pleural biopsy did not show any mycobacterial tuberculosis. Because of the plasma cell richness, the biopsy was discussed with the pathologist also, and they also felt that we can run an IgG4 marker, which showed that the IgG4 was positive in the high power field, and the ratio is around 38%. The other microbiological findings, AFD smear and fungal direct microscopy, were negative. And since there was eosinophilia, special biopsy PCR was run for parasites like strongyloids and endomoeba, which were negative. Important thing is the serum IgG4 was low, it was 1.24. So with this, we came to a final diagnosis that it was an eosinophilic right side pleural effusion, a probable IgG4 related disease, because it did not fit the definite criteria for IgG4 disease by definition on ratio, and the typical storiform fibrosis were not present in the biopsy as well. With that, the patient was started on steroids of 0.5 mg per kg, and the slow taper was done around 2 months, and a second-line agent was started, and is currently on follow-up. This is his current chest X-ray. As we can see, the effusion has regressed, and clinically also the patient has symptomatically improved.
Thank you, Dr. Avinash. Now we start the questions on this case. The first question is for Dr. Nagarjuna. How common is eosinophilic pleural effusion in your clinical practice? And what are the common causes of eosinophilic pleural effusion?
Sushil sir, actually, this is a very important thing, and we had looked back at our data. I think over the last 10 years of our thoracoscopic data. In fact, this question we had tried to look, and we had roughly, I think, if I remember correctly.
Can you speak out a little loud, Dr. Nagarjuna? We are getting messages that you are a little low on yours. voice.
Seriously. Okay. So we look back at our data and trying to address this exact precise question, how common is eosinophilic pleural effusion in our practice? So this is mainly looking at our thoracoscopic data. So we had found that eosinophilic pleuritis or eosinophilic pleural effusion contributed to less than 1% of all the effusions we ever seen. So that is our numbers. And common causes of effusions, eosinophilic pleural effusions. I think for all of us and all the students here, the two most common causes are presence of air or blood. I think this is something which we should not forget. So the first question which I wanted to ask Dr. Avinash also was a pleural tap done earlier, prior to the one which you had presented? So if there is no pleural tap and if it is not a hemorrhagic tap, then I think we would consider it as to be a probable true eosinophilic pleural effusion. So that is the first and foremost thing. Second, if it's a true eosinophilic pleural effusion, then what are the common causes we see? So eosinophilic pleural effusion, the two common causes which we encounter in our practice are, one is drugs. So I think we have had around maybe not large numbers, but 30% of our eosinophilic pleural effusions are drug induced. I think we should actually go back and take a very significant in-depth history. Dr. Avinash has told me that he is not on any drugs. Second cause would be parasitic infections. Because this case, if we had not had the final diagnosis before itself, parasitic infections are another cause of eosinophilic effusions, especially in the rural Indian setups, that has to be considered. Then there would be a significant chunk of them where we didn't get a diagnosis. So that also is there, where we don't know what exactly, even despite doing a biopsy, we only could come up with an eosinophilic pleuritis and nothing beyond. Also, diseases like ABPA, EGPA have been occasionally reported to have eosinophilic pleural effusions, and the remaining whole list would be an uncommon cause of eosinophilic pleural effusion. I think this is roughly in our practice. Even IgG4 presenting as eosinophilic pleural effusion is something I think I have not seen as of today. So it's an uncommon cause of eosinophilic pleural effusion. So whenever it's an eosinophilic pleural effusion, in our data of maybe double-digit numbers, despite doing a thoracoscopic pleural biopsy, I think in 30 to 50% we are still clueless and we end up giving steroids.
Thank you, Dr. Nagarjuna. Now, as per the literature, they said that about 1/3 of the patient with eosinophilic pleural effusion may actually turn out to be malignant. Because the previous
That is
teaching,
also-
I call back, we go back. The previous teaching was that if you have a eosinophilic pleural effusion, less chances of malignancy. But the current recent data suggests that from like there are studies which show about 17% to up to 34% patients who had eosinophilic pleural effusion later turned out to be having malignancy. That's something we need to think about in case we have a eosinophilic pleural effusion. And the rest of the other things which you have already mentioned, along with that, a patient with a post-CABG patient or patient with pulmonary embolism, and then, as you said, rightly said, drugs, and sometimes occasionally even with TB, you may get a eosinophilic pleural effusion. So there's a whole list of causes. Sometimes asbestos-related pleural effusion can also have a eosinophilic pleural effusion. So for the residents and PG students, you need to always look through these possible causes and then and try to make a definitive diagnosis. I think we move on to the next question to Dr. Radhika. Dr. Radhika, how often do you see eosinophilic pleural effusion in malignancy? What is your experience on that? And what are the malignant diseases which can cause eosinophilic pleural effusion? What's your experience in Indian context?
So we do see eosinophilic effusions with malignancy, but not to the tune of 87% in this case. So, with malignancy, you would see them in the tune of, say, 10 to 20%. But when it crosses like beyond 40-50%, in fact, malignancy gets little less likely. But to be honest, it is not very common. So we don't see malignant effusions very commonly as the cause of eosinophilic effusions. But I would definitely, if it's more than 40%, I would actually be a little less concerned about malignancy. Which kind of malignancies? I think the few that I have seen when the eosinophil was 10 to 20% turned out to be lung actually. But I think it can be probably associated with any other malignant effusion.
Thank you, Dr. Radhika. Yes, very important point which you rightly mentioned is any patient who has a high eosinophilic count, more than 40%, the probability of malignancy becomes less. That's something important point. Dr.
Nagarjuna, so how common, I mean, I think you have answered this. IgG4 pleural disease is a rare entity, but as anyone in the panelist have seen, because this patient also, I believe, Avinash, this tap was done just once, and it was a
Yes,
non-hem
ma'am.
tap.
It was a straw
And,
colored one, ma'am. Yes, ma'am.
and because the patient was a VIP, everything was done, the PET CT and this and that. And any undiagnosed pleural effusion, you go ahead and do a medical thoracoscopy, which was entirely normal, except for those linear thing. And I only did this one, so I can say with confidence. So how, I think Radhika has also answered the same thing. I was asking if when the pleural effusion is eosinophilic, is occult malignancy a possibility, which has been answered. Um, I would ask the other thing. Uh, do you think, based on this clinical history and whatever the workup has been done, because this was an MDT was done, and then finally the nearest diagnosis was IgG4 related pleural effusion, though a rare entity, do we think there could be any other option or any other diagnosis could be there for this patient?
And did we rule out vasculitis? I didn't see a ANCA
Yes.
level.
No, it was done.
It was
Every
done, ma'am.
possible thing was done, actually.
It could just be a eosinophilic pleural effusion, right? Because IgG4 just manifesting as a pleural disease without any other, uh, they typically have, like, the paraaortic fibrosis, or, some mediastinal lymph nodes or lung nodules, but just presenting with nothing and just an effusion is a bit odd. Secondly, a biopsy also didn't get any evidence of storiform fibrosis, which is very characteristic of IgG4. And now it's not the IgG4 blood levels or the IgG4 levels
Glow.
in the biopsy, which is the only marker for IgG4 disease. So I would probably, label this as a idiopathic eosinophilic pleural effusion rather than labeling this as a IgG4 disease. And of course, I would get the rheumatologist's opinion.
So,
Yeah.
indemnity rheumatologist was there, and they only suggested that this is most probably IgG4 disease. So, any
I
other,
understand.
yeah. I mean, we understand that despite the complete workup, we were not able to, put on one diagnosis for this patient. Medicine is very, very difficult, especially if these are VIP patients. So,
Ichema, that's
Nagarjuna,
what
yeah,
I
please.
wanted to say, that earlier also we had similar frustrating experiences with eosinophilic pleuritis,
Right.
where we
Yes,
ended
sir.
up labeling them, well, despite the biopsy is the best you can do. And if your
Mm.
biopsy doesn't show anything beyond non-specific eosinophilic pleuritis, you are stuck.
Yes,
You have a
yes.
PET scan.
Yes, sir.
PET scan is not showing disease uptake anywhere else. So I think that's what I said. 30 to 40% of our eosinophilic pleural effusions, the final diagnosis was idiopathic eosinophilic pleuritis. But the only good thing about these is that they are all the steroid response. So any eosinophilia steroid
Yeah.
response. The only question
Yes.
would be how long to give
And
and
relapse.
what would be the natural course.
Right.
So I think this is something
Yes.
which patient will decide, and we have to follow up and see.
Yes. Yes.
Sure.
I think we now move on to the next question. This question is for Dr. Aparna. This is from the postgraduates. This is a very common question asked. And what are the things you look for while doing an ultrasound in patients with pleural effusion? And is there any simple method of quantification of pleural effusion? I think we need your input, Dr. Aparna.
Sir, I think again, we don't do much of the ultrasounds. Richa only will be able to answer this better, I think. But yeah, I mean, we just look for loculations, any pleural thickening, any nodularity. That is the main things that we look for. And any, like, is it like a clear fluid, or is there some debris that is, there's some mobile echoes within it, which may indicate that it is like exudative. Whereas if it is clear, maybe it's more like transudative. But I think rest of it, Dr. Richa may be a better person to answer, because they do most of the pleural ultrasounds in our institute.
I think Richa, please answer this question. I think the ball is in your court.
Just tell me once again, was it the quantification part of it?
Yeah, first thing is that what are the things you look for while doing an ultrasound in patients with a pleural effusion? What are the things you look for? And second part of the question is there a simple method of quantification of a pleural effusion? If yes, then how?
Okay, sir.
And
So
what?
I think I'll just quickly answer these. When we are looking at a patient, when we are doing an ultrasonography of the patient, the first thing which we look at is roughly how much is the amount. So if it is less than one intercostal space, or it is just localized to the posterior recess, we say minimal effusion. If it is one intercostal space, it is mild. Up to 3 is moderate, and more than 3 is large. Is rough estimation. It may not correspond actually. There are lots of formulas which I certainly don't remember right now, but wherein which you can feed the things. I mean, these are mathematical, very simple things. If somebody is interested, I can send it off, with which you can find out roughly how much is the effusion. I mean, in terms of quantification. The other thing which comes is what do you look. So I would look like, one thing is how much is the fluid. Second thing, whether it is having septations or not. Third thing, is pleural thickening present? And if pleural thickening is there, is it smooth or it is nodular? Also, I would like to look at the diaphragm and diaphragmatic pleural thickening and nodularity, because that gives me an idea towards whether we are looking at benign or a malignant disease. At the same time, there are certain signs we will try to look at. How is the morphology, or how does the pleural effusion look like? Does it look black, or does it look having lots of cells in that? And based on that, there are lots of criteria where we can differentiate between malignant and benign effusion. So apart from that, when I'm looking at the pleural effusion and I'm thinking that the pleural thickening is there, nodularity is there, then I would also like to look at the underlying organs, so liver on the right and spleen on the left, to look if there are some some clue to say if there is any metastatic deposit or things like that. Plus, yeah, those are the things. If I'm looking at the pleural effusion, I would certainly like to look. And then whether the color sign is positive or not, to differentiate between loculated versus free effusion. I think I can keep on speaking for 2 days together on ultrasound.
Thank you,
Thank you very
Richa.
much.
I think now we move on to the third case. I think we are going late. We are running late. So I request Dr. Manas to please present the third case. Dr. Manas Minga. Yeah.
My slide visible, sir?
Yeah, please.
Yeah. So I'll go ahead with the case. 53-year-old male, not admitted with me currently right now, but then he came.
Can you make it full screen, please?
Yeah, sure. I have made it. Yes.
Yeah.
Not admitted with me currently, but he just first came to my OPD for an opinion for pleurodesis. So he was diagnosed as a multiple myeloma at age of 32. And he has been on treatment since then. A lot of therapies have been changed. He has underwent autologous bone marrow transplantation, and next therapies were donor lymphocyte effusions along with a lot of medications. Point to be noted: he has received a lot of dexamethasone as a part of therapy for multiple myeloma. And initially, to start with, he had no comorbidities, but by the time he has come to me, he is bad hypertensive, type 2 diabetic with CKD, and he had a DVT in year 2021. He presented with complaint of progressive dyspnea, coughing, right-sided chest pain, oral ulcers, suggestion of poor nutrition, bilateral pedal edema. So this was the X-ray, done maybe in the month of March. He was admitted to primary care, nursing home setup because he has been receiving a lot of care and that was closer to his home. He underwent diagnostic aspiration at the first. It was lymphocytic exudative with low ADA. Cytology did confirm multiple myeloma. So that was it. LDH was around 752, not mentioned here. And next, what they did was therapeutic tapping multiple times. He had come for second opinion. So my thought process was, first is patient's fitness, comorbidities, all were assessed, patient's wish, and obviously assessment about his expected lifespan or definitive therapy which could be offered to the patient. So there was some new trial drug, teclistamab, which could have been offered to the patient, but he was not sure whether he was fit for the trial or not. So mainly, now the intention was to give a palliative treatment to the patient to relieve his symptoms. So ICD was inserted outside, and he came to me with an ICD. They had a beautiful record maintained there, and daily output was around 300 to 500 ml. It was a high output effusion. I had suggested him pleurodesis, chemical or thoracoscopic after admitting and assessing for the fitness. That was the plan. So patient had requested. So patient wishes is one of the important factors in the decision. He requested, and his physician also wanted to assess him for the fitness and optimize the comorbidities. So he went back to his nursing home and requested me to come back in a week's time for the treatment. So now he comes to me. I got a call on day 8 that patient has a new onset fever, say high grade, 101, 102, recorded almost throughout the day, relieved only with paracetamol. He came to me on day 9 when he had hypotension. ICD output had come down. That is what I could see from his charts maintained at that center, and from 50 to 100. And now it was frank pus from the ICD pocket. And pleural fluid culture was sent, which grew Streptococcus pneumonia. Patient was fluid resuscitated, and low dose noradrenaline was started. Treatment as per the sepsis protocol. Now on day 10, day 11, ICD output was nil. So this was the X-ray, and a CT scan was done to plan. Do we need to discuss radiology here, or next slide?
Yeah,
I think
can
we
ask.
can discuss it here itself.
Yeah.
Sure, sir.
Dr. Aparna, please.
Yes, sir. Yes, sir. So basically now we're seeing that it's very much loculated, the pleural effusion, and this is a plain CT. So it's a little difficult to say whether everything is like mass and thickening, or is that a high density kind of pleural effusion. So if it is like pus and empyema, the effusion may look very dense on the plain CT. Once we give contrast, we may be able to see that the pleura is enhancing and the pus is the center, that split pleura-like appearance may be there. But at present, what we can see is that it's very loculated effusion. Maybe there is thickening also. We are seeing it along the mediastinal pleura also, that there is thickening, and something along the anterior chest wall just next to the sternum in the top image, we are seeing some thickening there also. And I think in the spine, he has had some surgery before. Some laminectomy defects are there in the spine.
So it was actually diagnosed as plasmacytoma, intraspinal and extramedullary.
Okay, sir.
To start with, that is how the decompression was done.
Okay.
So now streptokinase was out of question because it was frank pus coming out, and we did an ultrasound. So ultrasound showed 2 more pockets. The ICD pocket was completely drained, so ICD was removed, and it was very painful to the patient. So there were 2 more pockets. Now question is which therapy to choose. Patient was having a lot of comorbidities, and he was absolutely unfit for any thoracoscopic intervention. I just preferred, because patient had an empyema, I was anticipating some sort of pleurodesis like effect, and preferred to tap 2 loculi which were done under ultrasound guidance. So USG guidance, largest pocket of collection was aspirated. This is an X-ray post aspiration. The effusion was also exudative with neutrophilic predominance. This was the X-ray at the time of discharge and 10 days post-discharge. So pleural effusion has not caused any symptoms to the patient, and it was very well contained. Here, what I conclude that empyema with malignant pleural effusion can sometimes be very tough, and there could not be a guideline or a fixed protocol. One protocol or one size doesn't fit all. Personalized approach is required, and in this case, I preferred conservative, considering poor general condition and multiple comorbidities. Empyema, because of causing multiple loculations, did give pleurodesis-like effect. So even now, I am following up with the patient, and patient received teclistamab, which is a targeted therapy, and because of cytokine release syndrome, which is a side effect of that medicine, patient is on ventilator. Tracheostomy has been done, but there is no recurrence or increase in the pleural effusion, or we are planning to wean him off and remove the tracheostomy tube.
Thank you, Manas. Richa?
So Nagarjuna, a very common thing, even I'm sure many of the people would be seeing, and so do we. Patients do come with complicated effusion, or I'm sorry about this one. Patient do come about to us actually very late, so they might have lots of aspiration done, and the fusion would be complicated. But when you finally diagnose, it is malignant pleural effusion. So if the patient with malignant effusion develops secondary infection, how do you treat them? Is there any role of streptokinase or medical thoracoscopy in such patients? What are your comments on that, or opinion?
I think the first thing is we discuss with the oncologist what is the likely oncological outcome. That is
Right.
that is the first thing we do. So if the likely survival is longer and the oncological outcomes are supposed to be perceived positively, then we can be a little more aggressive. But if the oncologist says the survival is lesser and is purely palliative, then we have to choose accordingly. I think that is a very important thing which we have to picture in. And the general condition of the person. So if the person has a malignant effusion which is loculated because of a secondary infection, so I think it has to be treated on lines of a parapneumonic effusion or a complicated empyema. I think that is the basic thing. The only extra thing is the expected survival. So all the things which we would normally do for a parapneumonic effusion are not wrong if we feel that the person will survive longer. So we can try fibrinolysis, we can do adhesiolysis, but the more aggressive approaches are reserved only if we feel that the person will survive longer. For example, if we are looking at a terminally ill person, we would not offer them a VATS decortication or a VATS adhesiolysis. We would choose a much simpler thoracoscopic adhesiolysis or a fibrinolysis. I think there is no one answer, I would say, madam, but
Yeah,
I think this is how I would put it.
agree completely. I think so. When we are even planning pleurodesis, we have to be very careful, make sure it is done in a very sterile manner. And there are cases where people do pleurodesis and patient ends up having empyema, or the vice versa, because of repeated aspiration, they have introduced infection, and one effusion has become complicated. So sterility doing the procedure is very, very important, I think, for everyone. It should be written in golden words like in Bible, that you have to follow the sterility. So and as you rightly said, if it is complicated, it has to be treated like an empyema. So drainage and fibrinolysis plus minus if it is needed, and then again antibiotics. And you would certainly not like to do pleurodesis in these patients at this point of time. So Radhika, if you're doing a medical thoracoscopy for a patient, and we are suspecting malignant pleural effusion based on the macroscopic appearance, would you consider talc pleurodesis at the same sitting, uh, or would you not?
So, if you are reasonably confident of the macroscopic appearance of malignancy on, your thoracoscopic appearances, and you've got adequate tissue, and your underlying lung has expanded, then it's very reasonable to do a pudraj at the same point. But if there, even if there's an iota of doubt, then you can absolutely leave it, and you can in fact even do a slurry later through the tube itself. The chest tube that you have, after 2 or 3 days, once you've had your histopath results, or, once you know that the lung has completely expanded, because now we know whether you do a pudraj or you do a slurry, it's equally efficacious. But yes, if I'm reasonably confident of malignant diagnosis, lung has expanded, and I've got sufficient tissue, I would definitely do a pudraj at the same point. But if there's any of these three are in doubt, I would not do it. Wait for the histopath, see the lungs expanded, and then do a slurry through that.
Agree.
Thank you, Radhika. Now, our next question is for Dr. Arvind Kumar, sir. Sir, when is the situation when you consider doing surgery or VATS in a patient with malignant effusion with a multiloculated empyema? In which patient you would consider doing it, sir?
So thank you for that question, Dr. Sushil. It's a very difficult situation. Reason being that these patients have tumor deposits not just on the parietal pleura, but they oftentimes also have a lot of tumor deposits on the visceral pleura, on the lung surface. And as I said in the beginning, that the first thing that you want to do at the end of your decortication or whatever pleurodesis you are doing is to have a complete lung expansion. And if you have tumor tissue present on the lung surface, there is no way that you are going to be able to decorticate that lung, because if you try removing those tumor nodules, you'll end up causing massive lacerations with a lot of air leak post-op, and you'll make the patient miserable. So these are often situations where, if we know beforehand by looking at the CT or PET that the lung is collapsed and there are a lot of deposits on the lung surface, we avoid taking them up for surgery. In fact, those become then candidates for persistent drainage and those APC catheter, etc., but not for taking up for surgery. While saying this, I, with your kind permission, would add another situation which we see very often, that patients have pleural effusion. Now, it could be malignant, it could be benign, tubercular. And we have patients who've been aspirated 8, 10, 12, 14, 16, 18, 20 times. Every third day they go to radiologists, they get aspiration done. My question to Dr. Richa and Dr. Sushil is, instead of doing so many aspirations, why don't people just put a chest tube and have one-time complete drainage of the entire fluid? So many times we see things which started as simple pleural effusions turn into multiloculated empyema. To some extent good for us, but then not good for patients. So I would say that this practice of multiple repeated aspirations, most of these aspirations are done by radiologists in their outdoor clinics. And you can imagine what kind of asepsis would be followed in those outdoor radiology clinics spread across the country, and you actually unnecessarily introduce the infection. Why not, if anyone who requires more than 2 or 3 aspirations, why don't we put a chest tube? Dr. Richa, it's a question.
No, sir, 100% I agree. And we don't do repeated aspirations. We do follow what you are saying, putting in the chest drain. So, India is so vast, sir, and that is why we started, we tried doing up these pleural diseases, MDTs as well, to give up the message that what are the right practices. Uh, I think we also get lots of patients where they have done multiple aspirations. So there may be 2 or 3 things which I feel, sir. One thing is the doctor who is asking aspiration to be done by the radiologist, he or she is not confident to do the same, or they don't have the facility to do the same. The other thing is the acceptance of the patient to get a chest tube done. Uh, is also one of the factors which we find that when they offer, पेशेंट सेज नहीं ट्यूब तो नहीं डलवाना है हमें, आप ऐसे ही निकाल दो. So there may be lots of things, sir, I would say, but yes, patient needs, if more than one time patient is requiring aspiration, it should be a chest drain. And yeah.
So logistics and patient non-acceptance reasons notwithstanding, can we give a message that anyone who needs more than twice or thrice aspiration should not be sent or taken up for further aspirations? Every effort should be made to have a chest tube and have complete drainage. Keep it as long as required and then take it out. Thank you.
Agree, sir. Agree, sir. Thank you.
So, Dr. Sushil, have I answered the question about
Yes.
malignant effusion? It's a very
Yes.
difficult situation. And trust me, if I get these patients referred, most of the times we don't take them up for surgery for the simple reason that the lung will be collapsed and there will be a lot of tumor deposits on the lung surface. And there's never a situation where you would be able to do decortications on them.
Yeah. Thank you, sir. I think we have got the answer that yes, in such situations, we may consider doing using streptokinase or medical thoracoscopy in case the patient's overall condition allows it. Do very minimal procedures, if at all that is possible. Otherwise, restrict to palliative care. You agree, Dr. Nagarjuna?
Yes, I think it's important to not be over-aggressive in such patients. I think what
Yeah.
Dr. Manas has done was perfectly correct. He removed the tube which was anyway non-functional. The other 2 pockets which were there, he has done a single-time aspiration, given appropriate antibiotics, and the infection did the wonderful job of pleurodesis. So I think all things done. So I think the patient was fine despite an inflammatory storm. The pleura stuck to each other, and there's no recurrence of effusion.
Thank you. I think we now move on to the last question to Dr. Radhika. Radhika, would you consider doing an image-guided pleural biopsy instead of a thoracoscopic pleural biopsy in a patient with undiagnosed pleural effusion? What is your take on it?
So I would do a image guided biopsy. So there would be two or three prerequisites that I would look at. If I can see obvious pleural thickening on the on ultrasound. So as Richa ma'am said, alluded to it earlier, that you look for a smooth pleural thickening or parietal pleural thickening. So if you are seeing pleural thickening, then yes, definitely. And also I would want some amount of fluid. So you would want some amount of pleural fluid, because your biopsy needle is going to go through the pleural surfaces. So you would need that buffer for the needle. So if you don't have enough fluid, you're probably going to puncture the lung. So if I'm seeing obvious pleural thickening and there is enough fluid for the needle to go in, that's when I would, and of course you've ruled out, like, bleeding diathesis and INR and all of that is corrected, then definitely I would consider doing image-guided pleural biopsy.
Thank you. I think any more questions from anyone? Richa?
No, sir. I think we have a good discussion. I tried, and other panelists also tried answering uh, lots of questions. Some still are remaining. Maybe I don't know how to answer them.
But it still is a good start, I believe.
Yes.
Yes.
Um, so I'll just
Maybe
ask the
maybe they can post in that
right.
PN group so that
Right, right. So I would request the technical team, if all the open questions which are not answered, can you please make a note of them and send to me or Sushil sir, and then we can put it up in the IPN group for the benefit of everyone. So with this, we would like to conclude our first National Pleural MDT, and my three takes would be from case one. When in doubt, do not mess, refer it to the surgeons. My take from the second case would be, not all cases fit into the textbook definition or a textbook pictures. This is TB, this is this. And in our clinical practices, all of us are encountering such cases. So I would say keep chasing until you get an answer. Do not leave the case in between. Do MDTs, and even if with that the things are not settling, pleural MDTs are here. And other thing would be refer it to the specialist, but do not try to give empirical treatment for the patient. And my take from the third case would be that, as I think we have already discussed, that please maintain absolute sterility while doing any of the pleural procedures, because you are entering into the sterile cavity, and do not cause any iatrogenic complications for the patient who is already troubled. And try to be less aggressive. Risk and benefits you should be weighing, and then take a decision in the interest of the patient as well as a physician also. So with that, I would like to thank each and every one of our panelists who have taken out the time to come and discuss very openly. My thanks to all our case presenters as well, and to all the attendees who were so active during the thing, and they were bombarding us with the questions. So thank you everyone, and if any last comments are there from anyone, we would be happy to take it.
So please.
Small comment, but actually a repetition, but I think a repetition which is needed. If the lung is not fully expanded, please do not attempt any kind of pleurodesis, be it betadine, blood patch, talc, or any other substance. Attempt pleurodesis only and only if the lung is fully expanded. Otherwise, you will end up causing a trapped lung, which will never help the patient. Thank you.
I think We close the session now. Thanks to all the panelists, all the faculties. It was a wonderful experience today. And we'd like to continue this MDD every alternate month. That's the wish from our end. And we want to have your comments, please.
Sir, and we should also thank both Richa Madam and Sushil sir for conceptualizing this National Plural MDT. Huge shout out. And
Nagarjun, we
Thank
should
you.
actually
Yes.
express our thanks by clapping
that's
for
what I was
both
saying.
Thank you.
Dr. Richa and Dr. Sushil Jain. Brilliant idea, brilliantly executed.
Thank you, sir.
Thank you so much, sir. Thank you.
Absolutely.
I think now we close.
We had a great attendance, so thank you so much. We've had a lot of discussion and a lot of interest being generated.
Any more comments?
The three different cases, three different messages. It's really nice. And I think the message has actually passed on to the people who actually require it.
Thank you so much.
That's the need of the hour. That's the need of the hour.
Thank you so much, everyone. And happy weekend and happy flying, Radhika. And good night, everyone.
Thank you.
So much.
Good night.
Thank you.
Thank you. Good night.